Our next session will be a panel discussion entitled The Normalization of Workarounds in Healthcare, an Ongoing American Crisis. The panel moderators are Christine Pontus and Dr. Janine Simonotti. Dr. Simonotti is an associate professor in the Nell Hodgson Woodruff School of Nursing. She is an internationally recognized health services researcher with expertise in nurse workforce issues and the quality of patient care. Christine Pontus is Associate Director of the Division of Health and Safety for the Massachusetts Nurses Association. She is a board-certified occupational health nurse who is currently involved in identifying and analyzing research, policy, and current trends in the field of occupational health and safety as it impacts nurses. I will now turn the floor over to Chris and Janine, who will open the panel for discussion and introduce the remaining panelists. Thank you.
Well, thank you very much, Kevin. We so appreciate you bringing everyone together today from a global and national basis. It's been truly amazing, and it's been an honor to be on this panel. Today, we will discuss the unsafe practices and dangers involved in some of the necessary workarounds that healthcare workers had to deal with on a daily basis to deliver care. The previous speakers have set up this panel for nothing but success because they have supplied the data, the rationale, and the reality of what our speakers will now talk about that they experienced. As the title implies, the normalization of workarounds in healthcare being an ongoing American crisis was way before the pandemic. As our healthcare systems were forced to a just-on-time system led by people who had no idea of what healthcare was, but leading to a bottom line. We today are going to have a formal discussion of what a workaround method is for overcoming problems or limitation in a program or system. It is often bypassed of a recognized problem or limitation in a system or existing policy. A workaround is typically a temporary fix. It implies that a genuine solution to the problem is needed and necessary. As one of the presenters today, Betty specifically, and I came up with, a workaround is an action relating to completing a task or procedure in a way outside of the usual process due to the lack of resources. I will now introduce Janine, who, as you have said, is an international recognized services researcher with expertise in nurse workforce issues and the quality of patient care. She uses an interdisciplinary approach to better understand work-related outcomes of acute care nurses and the patients for whom they provide. Her research has been cited for its expertise on nurse outcomes such as job satisfaction, burnout, and patient outcomes specifically related to healthcare-associated infections and the sequelae of infection, such as extended lengths of stay, hospital readmissions, and mortality. Janine will speak about workforce issues that impact specifically the furlough that we as nurses experience. Thank you, Janine.
Before we move on to our expert panel, and I would just like to take a few minutes so we don't cut into their time. I'd like to remind us that the healthcare workforce is in crisis. As with other professions, we're seeing the Great Resignation. In fact, in healthcare, many professionals are calling it the Great Awakening. And it's resulted in a mass exodus of nurses and other clinicians from the profession. Recent figures are quite frightening, to be honest. It suggests that new nurses are leaving the profession within the first 2 years of practice, and that the average tenure of a nurse currently is 2.5 years. So I'm going to keep it short because our panelists have some really enlightening stories from the front lines to share. And with that said, I'd like to introduce our first panelist, Omid Razumpour. So briefly, in May 2020, as a new nurse graduate, Omid was a direct hire into the surgical and neurological ICU at the University of Minnesota Medical Center. Shortly after starting his position in the ICU, Omid witnessed his unit rapidly transition into a COVID ICU. It was during this time as a new nurse that Omid encountered numerous workforce issues, and he witnessed the impact of these issues on other nurses as well. This experience that he encountered in the ICU ignited his newfound passion for research that would focus on nursing workforce issues and the physical and emotional exhaustion of the frontline nurses. Sadly to say, but maybe good for us, Omid has left bedside nursing, and he's currently a first-year PhD student in the School of Nursing at Emory University. So Omid, platform's yours.
Thank you. Hello, everyone. Again, my name is Omid Razumpour. I'm going to reiterate a couple of things that Jeannie said. I graduated with my BSN in May of 2020. I was extremely eager to start work because I had gotten my dream job in the surgical ICU at a major teaching hospital. I was excited to apply my knowledge I had learned in school and try to make a change in my patients' lives. Things changed very quickly as my unit progressed into a COVID ICU. And by the time I left orientation in September of 2020, we hit our first big wave of COVID, and my dream job turned into a nightmare very quickly. Immediately, I started to see the nursing workforce issues that are so commonly seen around the country. A lack of safe staffing, a lack of physical resources, little to no mental health support, and absent leadership. My third shift off of orientation, I was tasked with caring for a patient who was prone on 4 sedatives, 3 pressors, and 4 to 5 other drips. This patient was in a special category where he was ineligible for ECMO and CRRT, but his family did not want to give up. I was assigned these types of patients for the next 6 months. It was death after death after death. I'll never forget the chemical smell in the freshly cleaned room where my first patient passed away. The room was so perfect. The sheets were tucked flawlessly. The trash can was organized so neatly. Yet everything that happened an hour before was chaos and trauma. The burnout around me was immense. One day I saw our mama nurse, we called her, because she was the rock of the unit. She knew everyone and everything, and she had been the hardest worker on the unit for the last 20 years. I saw her outside of her room, bawling her eyes out. Even she was hurting. And through all of my difficult times, this was one of the hardest things to see because it meant that every nurse from top to bottom felt extreme burnout. We were trying to provide care to a patient who we knew wouldn't make it, trying to comfort a crying family member who couldn't even see their loved ones. What did it feel like to watch your father or mother die over FaceTime? I couldn't even imagine. I still can't even imagine. We tried to comfort them, but there are limits to what we could do because it was always on to the next patient. I couldn't even, as bad as it sounds, there was a shift in spring of 2021 where I just couldn't care for my patient. I couldn't even care for myself. So how was I supposed to care for 2 other people, their families, and the medical team? That was actually my last day in the ICU. And I felt that every patient deserved a nurse who was fully committed to their success in that moment. And at that time, on that day, I could not do that. It really took me 3 to 4 months outside of the ICU to get back to baseline. I found my way back to research, which was another passion of mine during undergraduate. And as Jeannie said, now I'm currently a first-year nursing PhD at Emory University, and I'm very glad to have a great mentor like her. And my research topic of interest is nursing burnout, workforce issues, and how they interact with patient outcomes. I want to translate my research into advocacy, policy change, and business change. And my goal is to advocate for nurses in the same manner that nurses advocate for their patients, because nurses are such a vital part of our society, and burnout in our profession has a frightening trajectory. So thank you. I look forward to answering questions.
Okay, so I will now introduce Betty. Betty Sparks is an active and longtime labor advocate and union leader. She is currently serving on the Massachusetts Nurses Association Board of Directors, which guides the mission of the largest union in the Professional Association for Registered Nurses and Healthcare Professionals in the Commonwealth of Massachusetts. She also currently serves as a member of a federal disaster medical assistance team as a nurse specialist. Betty has 2 decades of nursing experience in the operating room and emergency department. Prior to that, she was an ICU nurse for 20 years. She'll now convey her experience. Thank you, Betty.
Hi, that's a tough act to follow. Thank you so much. That's, I just needed tissues for that. I'd have to compose myself now. So I'm going to relay, I have all this years of experience. Let me just start out what happened to me starting with COVID. The first time I knew about COVID, my federal disaster team was being deployed to California to help with the Princess cruise ship quarantine, if everyone remembers that, out in California. We took passengers and crew from the cruise ship, and we brought them to, they were actually vacant or hotel rooms, hotel buildings that were being renovated. The federal government took them over, and that's where we brought some of the crew members and passengers. And also we brought them to many Air Force bases. I was at the Travis Air Force Base with Mayan. So that was how we here in the United States was going to contain COVID-19, by keeping all these poor passengers and crew members in quarantine. Didn't work well, did it? So what we did was we would monitor them, teach them how to take their temperatures and things like that. And if they did start getting sick, then we would have to transport them. And that, from that deployment, once that was over, I headed back to my local hospital, where I thought for the last 15 years, I would be going back to the operating room. Well, what happened was all the operating rooms were shut down, and we're only going to be allowed to do emergency surgeries. And my hospital did not furlough anyone. They did redeploy. So I do my due diligence and I call my manager and say, I just came back from this first COVID-19 deployment, because you realize COVID-19 was brand new at the time, expecting to get a nice 2-week vacation or quarantine. Her first words to me was, Betty, you used to be an ICU nurse, weren't you? And I said, 20 years ago, yeah. She said, oh, awesome. We have a 1-day refresher course and it's tomorrow. Can you make it? I said, but I've been taking care of COVID patients. Shouldn't I be quarantined? Her answer to me was, well, you're going to be taking care of COVID patients again. Do you feel okay? And I said, sure, I feel fine. So I went for my 1-day refresher course, and the hospital redeployed me to the ICU, but not the real ICU, because that real ICU was chock-a-block full. So they opened up, they cleared out the surgical ward because there's no more surgical patients. And we made that into a makeshift overflow ICU. I stress the word makeshift because it was not, I mean, you weren't, negative pressure rooms, and it was all private rooms. So, and you didn't have the monitoring equipment, all the special things that you always have in an ICU. So we had to makeshift it. And then by that time, we were running out of respirators, ventilators as well. So we also had many, many different ventilators. And you also had, you were throwing in high flow oxygen things, people on CPAP. And these were all done in individual, beautiful private rooms, because this was a really nice surgical ward, because it was for your total joint patients. And so alarms, pumps, the many pumps that Omid had said about. Your patients run a lot of pumps and they alarm when they need more juice. And you couldn't hear them as well through the other rooms. And you had people like me who, after 20 years, is now trying to remember, get the old brain fog going. How do I take care of an ICU patient again? And then, so, we got through that. And you also, one of the good things that my hospital also did that I thought was great, and I had mentioned it, that there's one thing that OR staff, surgical techs, anybody, are very good at, is positioning a patient for surgery. Well, what we needed in putting these ICU patients prone, you got to realize they're full of tubes and you name it. It takes 4 to 6 people to turn these patients prone. We did not have 4 to 6 people to turn these patients prone. So what they did was they redeployed again these staff from the OR and made them into specialized proning teams. So they would come up and they would help prone the patients. Actually, they took over. They became so good at it that they like pushed you aside and they did it. It was absolutely awesome. So that was one of the workarounds that was awesome. And when they were doing that, they would be outside of a room so I could knock on the door and say, I need another syringe, I need some meds, I need something that I had forgotten or ran out of in my room, so I didn't have to don and doff 3,000 times to get things. So that worked out extremely well as far as that went. But the one thing, as Omid has so eloquently said, what we didn't do very well in a workaround was take care of our young nurses, because my particular hospital had just hired 100 new grads and did the same thing, threw them into ICUs, ERs, specialty units, which you never, ever in my career put in a new grad. And if you did, you had a mentor. You had a mama nurse like me, okay? I would have been your mama nurse, because I saw these new grads seeing death for the first time. And as he says, talking FaceTime with a family member, watching their loved one die, mama nurse couldn't handle it. I think I cried more tears than the family members half the time. It was one of the worst things I'd ever done. And to see a new grad have that be their first death, oh my God, I just couldn't imagine it. And not only that, if we had some traumatic deaths, anytime you have a traumatic death, you do a debriefing. There's always a debriefing. You get together, you talk about it, you support each other. You don't do it in a vacuum, you do it with other people. That never happened. We didn't have time. We'd be debriefing every 5 minutes, because I'm telling you, on a regular day, you lost 4 to 5 patients a day. You just did. It was horrible. So, and that's just my local hospital. Well, you heard I'm a federal disaster nurse. So guess what I got to do? I got deployed to California again, to Texas, to New Mexico, to Alaska, to Chicago. And time again, I saw the same thing. But you know what? It got worse. At least while I was in my hospital, I was working with nurses I mostly knew. I came from the OR and went to the ICU, so I didn't work with them on a daily basis, but I knew some people. I knew the hospital policies. I knew Massachusetts policies. So the state that I work in, I knew their policies. I'm now in other places, all over the, working in other hospitals, helping to decompress them, helping to be extra staff for them. And again, the same stuff was happening, but it was happening with nurses I didn't know, which is logical because I worked at a different hospital. The problem was nobody worked at that hospital. There was nothing but travelers and agency staff in all these hospitals, because we were helping, the federal government went in to help them. You can give me any number of staff, but it's not always the number of staff. You need the expertise, and you need staff that knows the hospital, knows the hospital's policies. And that was truly, truly lacking in everywhere I went. And then sadly, I'm seeing the same thing happening out here in Massachusetts now. It's that staff has left. There's no regular staff working in the hospital that knows the ins and outs, knows where the supplies are, knows where anything is. So I found that to be extremely difficult and really sad when I came back to Massachusetts and found it was happening here as well. I mean, nurses, as it was, you had to learn new equipment at all times, because depending on the supply, did you get the same syringe? Did you get the same needles? Did you get the IVs? I mean, all of us are real picky about the IVs that we use to start IVs, because we're all very picky about that. And they were different every day, no matter where you went. And just, respiratory staff was so overwhelmed. So now, luckily, as a disaster nurse, they had brought in, I learned how to use transport ventilators. Well, a lot of places where they ran out of ventilators, they brought in transport ventilators. So they were much easier for me to use, but not all the staff knew how to use it. And you couldn't always have a respiratory therapist right there because they were so busy. So the nurses had to pick up how to play with the new ventilators. I mean, usually a nurse knows how to use a ventilator. Show me the silence button in an ambu bag and I'll call respiratory, I'm good. That didn't work in these circumstances. You had to learn more about equipment that you were unfamiliar with. So that was like my hospital experience. Okay, but also on the DMAT team, we got deployed to administer monoclonal antibody infusions. So we set up a tent, which is what I'm used to doing when I go in disasters. We set up a tent. And when the patient came to the emergency room and tested positive for COVID, but weren't sick enough to be admitted to a hospital, but fit in a very tight criteria that they had at the time, they would just come over to our tent and we administered the antibodies to them. So they stayed for about 2 hours and we monitored them very closely. And that worked out really well for the hospital because they saw many, many less admissions for COVID. So that was really a good thing that we did. Unfortunately, it wasn't something that we're seeing across the United States. I know here in Massachusetts, we didn't do it. You're hearing more about it now, but back then, I think that was a miss that we might have been able to stop a lot of hospital admissions if we had done that more widely. And also, as jack of all trade, master of none, I also worked in mass vaccination clinics. So I administered in thousands and thousands of vaccinations in these max clinics. And I was not happy with some of the workarounds in there. And I was also not popular because I was not happy and I verbalized it. What they would do, they had multiple people who I did not know what their credentials were, and they would be drawing up your vaccine. So they would draw up a vaccine and they would put a sticker on it, that it was drawn up, and I would get a batch of 10 at a time into my slot. And I would diligently look and make sure it was the right dose, because nurses are used to drawing up their own drugs or have a pharmacist do it. These were not pharmacists. These were firemen. Some of them were nurses. They were not anyone that I knew. And occasionally I did look over and I would see unsterile technique and I would go and, excuse me, that syringe needs to be disposed of because it was unsterile. You just put it down on a chucks and your needle wasn't capped. And they would get very angry at me, but I'm the one administering this vaccine. So I know I used to have to, say that's an unsafe workaround as far as I'm concerned. I would have preferred to just give me the vial and I would draw up my own batch and get it done. At least I knew what I was doing. Also, we would get different syringes at all times, different needles. You would get a 1-inch needle one day, and then you would be lucky, and the only needles they had to give you were the 1.5-inch needles. We all know 90-year-old people have no fat. So a 1.5-inch needle was very, very difficult to administer. You would hit bone. And if you've ever hit bone, you don't want to do that again. And then there was another time they decided, we got different needles, and when they were drawing up the vaccine, it turns out that they could only get 9 doses out of this particular vial instead of 10. And they were trying to figure out why. Well, if anybody knows about dead space in a needle, there's dead space between the needle and the syringe. Well, because of the safety needle, that the cap that was on it, it was one of those orange ones that snaps and covers the needle once you give it. There was more dead space. So it made them get less dosage. So they thought the correct way to deal with this, instead of safety, was let's get rid of the safety latch so that we can get 10 doses out of this vial. And again, the unpopular nurse went up and said, no, that won't be happening. We'll get 9 doses and no needle sticks. How about that? So a lot of the workarounds and some of the safety things were not something that should be done. And again, would any nurse, I mean, once I spoke up, I had all my nursing colleagues that defended me and supported me. But I often wonder how many of them saw the same thing and never said a word. So that's my story. I think I covered everything. And
Okay, continuing. Our next expert panelist is Dr. Janet Haas. She's the CEO of Innovative Infection Prevention, a consulting firm focused on infection prevention in healthcare, public health, and the private industry. Before consulting, Dr. Haas was the director of infection and epidemiology at several hospitals in New York, most recently Lenox Hill Hospital. She earned her PhD in nursing from Columbia University and an MS in epidemiology from the State University of New York in Albany. She is the associate editor of the American Journal of Infection Control. She's the past president of the Association for Professionals in Infection Control and Epidemiology, we refer to as APIC. And she is the 2022 APIC winner of the prestigious Carol DeMille Lifetime Achievement Award. So, Janet.
Well, thanks for inviting me to participate. And I think that I was very lucky to be from a large healthcare organization with 23 hospitals, and that's known for some pretty compassionate and innovative leadership. And so we certainly had our problems. You know, when COVID hit New York City, it was like a tidal wave. But I think that I've told some colleagues, I never thought I would be happy to have been in the first wave of COVID infection. But at that time, everybody was on the same page. The healthcare workers were heroes. We weren't talking about violence against healthcare workers and some of the other backlash kind of situations that we've seen subsequently. But we were dealing with, on March 6th, we had the first patient come to the emergency department. And by the end of March, we had over 300 patients with COVID just flooding through the hospital. And our then governor in New York State, anticipating this kind of influx of patients who needed care, made some very staunch requirements that within 2 weeks, every hospital in New York had to increase capacity by 50%. So in addition to the mounting issues of sick people coming in, lack of testing, lack of knowing exactly what to do to best treat these folks, we were also converting the spaces that used to be patient care, but now are storage spaces or were office spaces into more patient care capacity, and closing down our elective surgeries and changing over the waiting, the recovery rooms and the pre-op areas for ambulatory surgery into more space for people sick with COVID, and trying to keep them separated from other people. Because, just because there's COVID doesn't mean that everything else stops. Strokes, cancer, heart attacks, just don't go away. So we're trying to maintain some safety for people who are coming in with other things as well. I was very lucky. We did not have any furloughs, and we had plenty of redeployments. And one of the things that I think everybody struggled with, and we have heard it mentioned here, was supplies, personal protective equipment, so on. So just getting enough supplies was challenging, and keeping the same supplies was impossible. We were very lucky because Betty mentioned that the OR teams are very good at positioning patients, and they're also really good at donning and doffing PPE. And so we had a squad of people that reported to me that covered the facility 24/7 to go around and make sure that people had what they needed, or if they didn't, that we figured out how to get it to them. We had a distribution center for additional PPE and a room that was manned 24/7 for the times when the distribution, the distributed supplies ran out. But this group of OR professionals helped people figure out how to don and doff without contaminating themselves, gave them just-in-time updates on, okay, we used to have the yellow gowns, but now we couldn't get those yellow gowns. Now we have blue gowns and they're the same thing, but just a different color. So I think we did that, went a long way to, number one, making sure people had some personal protective equipment at their fingertips, or if not, somebody was troubleshooting it for them, making sure that they knew that what was being swapped out was an equivalent or wasn't an equivalent, and here's how you had to do something a little bit different. Because, you know, you can't help it when you're at the whim of the supply chain. And I heard a really great author, she's a business person, and she said, we've talked about just in time, but we also have to think about just in case. And I think we really learned that as a lesson from the pandemic. Figuring out if and how to reuse personal protective equipment in a way that's safe was a challenge. And so having that group of people really was helpful in making sure people felt and knew that we were doing the best that we could. Now, you know, there are no miracles in that kind of situation. We couldn't, you know, grab N95 respirators out of thin air, but to the extent that we could do anything or reassure them that we were doing as much as we could, and here's how to extend the use of your N95 respirator and your other PPE in ways that were the safest. That was huge. We also had people that were doing exactly, I think Betty talked about this too, like get me an extra this or that. So we had people who were nurses who had worked in quality or worked in, you know, other places, outpatient areas. I'm not sure where all of them came from, but who did just that. So they didn't have a patient assignment in the ICU, but their assignment was to help extend the capabilities of the nurses who had the right kind of training to care for these patients. And so there would be always some extra people on hand to, hey, go get me this, go get me that for the patient care staff in the ICUs. We also had a very active chaplaincy department and integrative wellness nurse. We have had a few of those folks, and they were there with, they made a lavender lounge. They had people that were outside of the cafeteria that had essential oils that you could just put on a piece of gauze and tuck it into your mask so that you have that nice aroma instead of just breathing in your own mask air all day. And I think that these little things really made a difference, you know, for people's mental health and capabilities to just keep going in the overwhelmingness of this. And I think we were lucky because we thought this wasn't going to last. At that time, we didn't think it was going to last for years, right? So we thought we just have to get over this horrible wave and then we'll be okay. And at the same time, you know, the public really, I mean, I guess nobody does it like New York City. I love New York City, so I'm biased, but people were out banging pots and pans at shift change. There were people who were Broadway stars that were serenading people from their windows at certain times of day. So there was a lot of esprit de corps just from our public. We were really felt very supported in that way. There were notes from school kids. Thank you for taking care of people. And I think that really does a lot to lift the spirits of healthcare workers and other essential workers who maybe didn't get so much of that. I don't know that people were writing notes to the people working in the subways, right? That were really in dangerous conditions. But we should think about that because the essential workers really are where it's at and really super important to keeping everything going. So we also had very good communication. We also had a dashboard to say how many people there were in the hospital with COVID at any given day. It wasn't updated in real time, but it was updated daily. So anybody could see sort of where we were. And of course, people were really scared. I think Omid spoke, beautifully to, I was a cardiovascular nurse and now my unit is a COVID unit. And I'm not comfortable with all this infectious disease stuff. So it's not like we had a perfect situation where everybody felt great. People were really afraid. And so getting around to be in person, and the CEO of that health system is just an unbelievable human being. He was out at every single one of the hospitals, thanking frontline workers for the work that they were doing, which I think just shows character and makes a difference in people's willingness to keep on going, and treated everyone, the housekeepers, everybody, as being essential to this group effort. So in our hospital, the orthopedic surgeons didn't have much to do, and they volunteered to be on the proning team. So we had a variety of people, including orthopedic surgeons with respiratory therapy and others doing this, so that was any way that we could lighten the load of the frontline healthcare workers was something we were looking to do. And another thing that was an advantage of being in a large multi-facility system was that there was load balancing from all of the hospitals. So the hospitals that were in Queens were at the epicenter of the epicenter and just would have been really overloaded. So we would have, people that would come to various different hospitals to relieve the ones that were the most overloaded. All right, can you take one more person on a ventilator? Can you take one more this or that? But everybody worked together. And, I do infection prevention and control, and we were certainly very busy during this with, first of all, preventing transmission within the hospital, which is key, trying to keep our healthcare workers safe, trying to figure out if we were getting healthcare workers who were getting COVID, were they getting it from within the hospital, or were they getting it on the subway on the way to the hospital? Like, where is this coming from? And is this something that we have the ability to, are we preventing it adequately within the workspace? Or is the problem outside of the workspace and the messaging that people really have to be careful and find alternate ways to get to work if they can, and so on. We were so dependent on public transportation, and that was a very weak link for many reasons. And talking about some of the other people talking about disparities in care, the shelters for homeless people got shut down early in the pandemic because they were trying not to have a congregate living situation, but those people have to be somewhere. And so they were living in the subways. And so that made that unsafe and unsavory in many ways. They couldn't get into clean and all that stuff for a while. And they ended up, for the first time in the history of the New York subway system, closing down overnight so that they could clean and disinfect the subways for people. So it was quite an experience, but I think that with creative, compassionate leadership and the ability, with the scale of the health system that I was part of, we were able to do better than we might have in keeping people safe, in collaborating on if you couldn't get the drug that you needed for your patient at this place, the head of pharmacy drove to another place to get it. And I think everybody was 110% in, or maybe 1,000,000% in just trying to keep it safe for the patients, for the healthcare workers, to try and keep everybody's spirits up, including our patients and their families who are quite worried. And that's another stressor on healthcare workers that Omid spoke to, having that communication with family members. So there were some volunteers who were enlisted, chaplains and so on, to be the keepers of the FaceTime and make sure that there was communication ongoing with family members. Another thing that was done for our emergency department, where it was very stressful, right? So these people are coming in extremis sometimes, and once they leave, you never know what happens to them. I think the ED and the OR are kind of like that, where you don't know how the story turns out. And so they began bringing back at the morning huddle and the evening huddle, this patient that you saw 2 days ago is doing better, and they did worse, but now they're getting ready to go home. And we also implemented, every time somebody came off the ventilator, they would play a little bit of Here Comes the Sun over the entire loudspeaker system in the hospital. And that was something that one of the other hospitals came up with. So we were sharing ideas about that kind of thing, so that people could, have the experience that people were not all dying, right? Some people were doing well and recovering and going home. We also had a home care service that sort of developed pretty quickly. We were sending people with pulse oximeters to monitor themselves at home and calling them daily to keep them out of the hospital, but to not lose track of them if their condition worsened and they need to be brought back in. So I think that, it was the best of times, it was the worst of times, right? So it's horrible to have to live through that, but we came up with some very creative ways to manage our patients and our staff, not furlough anybody, and try to limit the moral distress and burnout of the members of our teams.
Well, thank you, Janet. That brings us to a question we had from someone in the audience. They said they appreciate the incredible work everyone has done, but wonder if you have a suggestion or best practice to deal with moral injury. So you just mentioned that. So I'm wondering if you could just speak to it, then I'll go around and ask Betty and Omid the same question. How's that?
I don't know that I'm the best person to speak to it, to be honest with you. My specialty is infection prevention and control, actually. But I think that compassion and showing that you're out there with people. I think that, a lot of nurses and other healthcare workers and other essential workers, not even beyond healthcare, really felt they were going it alone on a lot of this stuff. And that, when you're calling me to come into work, you don't have the equipment to keep me safe, or you don't have what I need to keep my patients safe. And so finding ways to be creative about preventing that moral injury and recognizing the extreme stress that people were working under, I think is a step toward that. And then I'll let my colleagues who might have more.
But before we move from that, Janet, there was, there's something that always kind of bothers me, and I would think it would lead to a lot of moral injury in New York City. And that was the refrigerator trucks.
Yeah.
I mean, can you explain what that was like? Because I remember seeing pictures, these huge refrigerator trucks were lined up, and you knew they were just filled with bodies of the deceased.
Yes. So that was hard. We had those trucks outside, as did every hospital. And it was also hard because we were a hospital in Manhattan on the Upper East Side, and there was a lot of press interest in trying to see the bodies being brought out. So we ended up renting like a tent. So there was an enclosed tent space from within the hospital all the way out to the refrigerator trucks. And there was a procedure. We're watching all of this with the death of Queen Elizabeth, right? The kind of solemn ceremonial way to deal with the death of somebody. And we tried to do, not quite what's going on in Great Britain now, but that the bodies were brought from the morgue by people who were trained to do this, who volunteered to do this at a certain time each day. And I think the chaplains were involved, and to afford as much dignity to each of those people as we could possibly do, and to keep the press out of it. And, nobody would like to see a picture of bodies being removed from the hospital and in any way unbefitting them. And especially if you know that you have somebody hospitalized there. So we took great care to make sure that that was done in as dignified and solemn way as was befitting this horrible situation. And that's the best that we could do, And don't forget that this was happening all over the city. My son happened to be in the Army National Guard and was on duty removing bodies with the medical examiners. He was deployed to remove bodies of people who died in their apartments, in their houses. So it was a whole other level of this, and then, more refrigerator trucks needed for that. And so there were so many people who, may have died of COVID or may have died of other causes in some parts because they were afraid to go into the hospital because they were afraid to get COVID in the hospital. So this was just a ubiquitous and horrible situation for everybody to have to deal with. And I think the only way that you can manage that, it's not like you have the capacity to store these bodies at the rate that people are dying. So you needed to have these trucks, but to make give people the dignity that they deserved and required, and that staff members wanted to treat them with, as you had to put them in those trucks.
Well, thank you, Janet. The question that came in also by one individual clearly stated that the staff where he works are being told they're not doing enough. So does someone want to answer or respond to that? This person in the chat is saying, what should a nurse do when they're being told they're not doing enough in this, in this kind of a crisis environment? It's for moral injury. This is what induces moral injury, when you're told you're not doing enough and you're giving your all. So what can we tell this person?
I have to say that that's not one thing I ever experienced. I said, like, as my CNO was, he showed up every day on the unit to, see what he could do to help. As always, I always had a suggestion, and he always followed through. He always followed through. Or if he couldn't follow through, he would tell me why, or give me a time frame when, well, we're going to get those 100 bottles of propofol soon, because 50 runs out in 15 minutes. So, I mean, he was very good at helping with that. The only time I saw it was that you're not doing enough came from frustration from a fellow, with what my peers, that they were just frustrated they weren't doing enough, or they couldn't do enough. I saw that more. Nobody ever looked at me and said, you're not doing enough. I never, ever saw that, but I did have to respond to many. It's like, we're just not doing it. We're not getting it done. I can't possibly, take care of this patient properly. And in those type of things, if I was able, which in many cases I was able to, then let me, see what I can do to help you. Is there something that I can do, or can we get, one of these helpers to do that for you instead? Stuff like that, more or less, because at that time everyone was fried. They were overdone. I mean, and as far as refrigerated trucks, yeah, one of my jobs was to fill those refrigerated trucks. And let me tell you, yes, we did it in the most dignified way that we possibly could, because that was not one of my favorite jobs, let me just say.
So Omid, I mean, obviously you were a novice, a new nurse, and your experiences were different from the others. So, what is your take on moral injury? Did you feel that, it was a huge part of what was going on in your unit? And do you think that, if things could have changed, what kind of change would have been necessary to alleviate what you were seeing?
Yeah, so there was a lot of moral injury on my unit. And we had quite a few new nurses who were there with me. And I really want to point out three resources that I wish we could have had starting as new nurses. I think Betty touched on this one, as nurse residency programs. I really want to emphasize the necessity of these programs, especially in the highly specialized units that we were in. It's obvious that it's a no-brainer. Every nurse should get some sort of support program as they transition into practice. And the goal should be to ease them into their new environment. Unfortunately for me, that didn't happen. Very rare, it seems now, but I didn't have a nurse residency program. We had a few instructional courses on and off, but nothing that was really impactful for me. I had to do a lot of self-studying, which I think had a lot of impact on my burnout as well, because I was taking time away from my personal life to go and study for work. So, but it did really feel like they needed nurses on the floor, so they pumped us out as quickly as they could. And we just really, to me at least, it felt like we were another cog in the wheel that wasn't taking nursing or patient safety into regard. And then staffing is the next issue. I think we can all agree that the bare minimum requirements should be safe staffing for nursing. Obviously, COVID it was a different situation. I had heard of stories of 5-to-1 ratios in the ICU during peak COVID, and 3-to-1 regularly in the ICU, even now, which is crazy to me. I can't even imagine that. And everyone that works with COVID patients can remember the running back and forth between 2 or more COVID rooms. We were trying to put on PPE as fast as we could to get tasks done because there was no one else there to help us. We didn't have CNAs, we didn't have float nurses, we didn't have anyone. So in an ideal world, which I don't know if we'll ever get there, but I think safe staffing, having CNA support, making sure you have a charge nurse who doesn't have to take assignments, that's a big one. A float nurse, clinical nurse specialist, and an active nurse manager. I think we all know the positive domino effect that would come from that scenario. And then finally, something that would have really helped me that I didn't have the opportunity to have was mental health support. So a lot of the times we talk about the patients we lost. That's the main thing. Patients we lost to COVID, but we rarely emphasize that we lost fellow healthcare workers to mental health struggles during COVID. And there's one individual in particular I want to talk about. His name is Michael Odell. He was the Stanford travel nurse who took his own life because of his time working in the COVID ICU and the difficulties he had as a nurse. It really hits home to me. And I want to read a couple of quotes that he said. So Michael said the following about his patients. I feel for them as deep as human empathy can allow. So that's how he felt about the patients. That's how I felt about the patients. It was never that we didn't care enough. I was at some points caring too much, obviously. That's why I got burnt out. So Michael went on to write about his struggles with COVID on his Facebook page. He said, I fear the long-term effects this may have on every clinical worker navigating this pandemic in these situations. Please don't think me selfish. I get that my level of suffering cannot compare to what these patients and families are experiencing, but the fact is that I have an amazing support system and people who love me and tell me frequently that they do. I fear for those who do not. And so I just want to say that was really impactful to me. 8 months after he wrote those posts, he took his own life. So in 2018, a research team from University of Michigan found that among female nurses, the suicide incidence rate was 17.1 per 100,000. as compared to the general population at 8.6 per 100,000. I'm very strong and passionate that we deserve more than the typical free counseling that takes 2 to 3 months to get an appointment, and more than a mental health Zoom every couple of months. Okay. COVID should have been the wake-up call that we needed to provide basic mental health care for nurses, because the mental health of our nurses should be looked at as an investment rather than a burden. And I think it relates back to what Dr. Burke said in her presentation. We're so thankful for everyone for what they've done so far. We understand your work is hard, and we really appreciate you. So those are 3 things that I wish I had as a new grad nurse.
Can I just ask another quick question? Because, and Janet had brought this up, how they had different well-being methods, or whatever we want to call it, for the providers. Like they had clergy, they had essential oils, different. Was there anything made available to you?
To the nurses, I didn't really get too much. The patients, yeah, of course. I mean, you could take the patient's essential oils, and that's what nurses did, because we weren't provided with that stuff. We were even struggling, as everyone else was, to get N95s on the 7th shift with a soggy mask. I mean, unfortunately, my healthcare system did not do as well as Betty's and Janet's. And it's very disappointing to me, because it was a massive hospital system. So.
Thanks. I'm going to ask Betty a question. We had, Betty, we had some nurses that actually were asked to work with the equipment that they generally don't work with. Did you experience that, for example, with ventilators? And because the situation became so dire, they had to really go outside their nursing normal capacity. What would you say to that?
Yeah, I did speak to that. Saying that, like, they have, we had to use many different ventilators, and anyone who uses a ventilator right now, it's like an R2D2. They're not very user friendly unless you're a respiratory therapist and you know how to do it, because there's so many settings. And these patients who are so sick that, depending on their lung capacity and how their lungs could respond to getting different tidal volumes and stuff, there's all kinds of things you tweak and turn. So I could not know totally how to do that. Occasionally, I was very lucky. As I said, I got the transport ventilator, and that was for patients who weren't as sick, so that it was very few dials that I was capable of turning. But most of the time, if those ventilators, those ones I could use, the other ones I needed respiratory therapist to come tweak them, because I could not tweak the high-tech ones. Also, we started with like the high flow oxygen. You get like the high flow oxygen, give 100% oxygen, and then you could up the flow till you like blew their sinuses out and stuff. And you had to know how to turn those dials. Now, in a normal situation, those type of high flow oxygen and BiPAP mask and CPAP mask, usually when a patient requires that, they are transferred to an ICU. That did not happen in this case. In this case, because the ICU was filled with ventilated patients, the nurses on the med-surg floors are now receiving these patients on high flow oxygen and stuff that they would normally have transported those patients to the ICU. So yes, and then when I deployed, I did work in some med-surg units, so I was able to help the nurses at that point learn how to use those. But normally they would the patients would be desatting to the 70s while they got their phone on the respiratory, trying to get respiratory down there. And respiratory was very busy and they couldn't. And it's like, okay, guys, let's just tweak up the oxygen. Let's tweak up the flow. We can't touch those because they've never seen those equipments before. And yeah, you had to either learn, or your patients were going down to 70, 60%, and then they were going to end up in these patients, as we all knew. Once they started heading toward their cliff, they fell right off that cliff, right in front of your eyes. It was so fast how fast they went down the tubes. It was amazing.
Thank you. I just wanted to bring in a statistic that the total reported illnesses more than quadrupled in the Bureau of Labor Statistics. So they came in for 21. So that meant they quadrupled from 19 to 20. They probably have even gone higher. And so according to BLS, that was a 4,000% increase in workplace illness. And a lot of that illness was, came from healthcare workers, service providing industries and technical business, but the highest was healthcare. My question to the three, and also Janine and myself, I question this. We as healthcare workers, this includes probably everyone in healthcare, are very creative and industrial workers. We're industrious. And I've seen this outside of healthcare. People will do anything to get the job done. We've become our own worst enemy in the sense that we have contributed to the problem in always outstanding the engineer who designed the process, for example. We outdid ourselves to the point where there was no more you could do to beat the system. Is that a fair statement that we've contributed to the situation by being too good at what we've done? By not stopping and saying, no, this is enough early on?
I think about that when I think of, how we here in Massachusetts passed the ICU law. That ICU is 1-to-1. Unless the nurse decides that my patients are okay, I can take a second patient. Okay, that's the ICU law. Omid, you would love that one. That's the ICU law here in Massachusetts. Okay, because of COVID, minimum was 2 patients. And yes, you are correct, Omid. We were taking 3 vented, totally lying, we went crazy. And guess what? The hospital said, hey, look at these girls. Omid. Look at these nurses. They can do it. Look at that. Let's just give it to them. And right now we're having a hell of a time going back to 1-to-1 here in Massachusetts. I can't tell you what hospitals letting them go back to 1-to-1. There's 2-to-1, and they're fighting for that. So yeah, yes, we did show them we could do it, but I don't know. I don't think we did it. Patients died. So I don't know what they're saying.
Well, I think it got to the point. What I'm saying is that there are some people that believe that because we didn't stop earlier, we became part of the problem. I mean, it's very, in a sense that we were part of the healthcare system. We were part of it that didn't work.
Well, I think, well, right now we have a crisis.
Yes.
There's no doubt about it. The nurses are gone. And I think what really happened were mistakes that were made at the onset of this pandemic. And it seems like they're mistakes that Janet's hospital handled very well. And that was furloughing staff and nurses. And I know we did that here in Atlanta. We furloughed a lot of nurses. And where did they go? They went to New York City. And they were making tremendous salaries compared to, because the salaries are quite low here in the South. And they were making something like $10,000 a week to go to New York City. And I think that was a cascade effect because you had nurses from all over the country that were going to take advantage of that. And I think that's what was, what began this whole change in the way care is being delivered. I think it was because of what was going on there and how that rolled out that now nurses decided to sign up with agencies as contract nurses, because as a contract nurse, they're quadrupling their salaries. And I think that's what really kind of led to the predicament that we're in right now. Either nurses have left because of fear and they took early retirement and it's over. The young nurses, like I said, there's evidence now that new nurses aren't staying 2 years. Omid is evidence of that. They're working with these agencies for higher salaries. So, where do we go from there? I mean, I would think, and, there's a lot of experts on this call right now. My honest opinion is that CMS has to go in there and redesign how, well, we don't bill for nursing services. That's the problem. There's no charge for nursing services. You get charged for a room when you're in a hospital, and that's your nursing care. So there's no way to manipulate, for a lack of better words, or adjust the charge based on your acuity or need for nursing services, because you're just getting charged for the room. And I think that would be an answer, because then hospitals would be able to offer more competitive salaries to the nurses. But those are just my thoughts, because now there's a whole financial piece that's come into play with this.
Well, speaking of what my experience is going to all these different hospitals, like you can't effectively work. Nursing and healthcare it's a team, and there's no team in temporary nursing staff.
I know.
You're,
there's
okay, you're leveling out. You're leveling out. There's nobody that is there on a regular basis. There's no consistency whatsoever. And it is very, very difficult when you're in an emergency situation. I know I can go in and start, resuscitating a patient. And I know Jane's going to come in and she's going to start giving me drugs. And I know Judy's going to come in and start doing CPR. And George is going to start ventilating the patient. Because I work with these people all the time. And we all know what we do. If this one's doing this, and I'm going over and doing this job. And you don't have that when you have temporary nurses coming. Like we're dealing with this they want compact language. Yeah, that's the exact same thing. You're going to get, a nurse from here, a nurse from here, and a nurse from here, but nobody from here.
lack of communication and
Oh my God, it's awful.
Yeah. And that's a nationwide problem. And we have to fix that, because I'm hearing the same. I know many nurses across the country, and I'm hearing the same reports coming from California. Those of you that follow workforce issues, you know that California is the only state in this country that has mandated nurse to patient ratios. That's legislation in that state. It's the only state with that strict ratio. And then they're having the same problem over there, where on a given day, almost half of their nurses are contract nurses.
And if I could add too, I have a lot of anecdotal evidence talking to nursing students because I'm close with them and they're in my sphere. And I can't tell you how many of them say, I got into nursing because I want to be a travel nurse. The money sounds amazing. That's scary to me.
And it is. And the agencies are really, they're taking advantage of the situation. There isn't a day that doesn't go by that I don't get emails or a hard copy mail, $100,000 sign-on bonus, plus moving expenses or whatever. So that's just adding to the dilemma of nurses that have, decided to retire or whatever. And the situation here in Atlanta, and I know from probably people in your cohort, Omid, the nurses have joined, and we call them travelers because they would at one point be going across the country or whatever. They like this, but they quit their jobs in the hospital, they resign, and they sign up with an agency, and they just travel around Metro Atlanta and quadruple their salary by doing that. But again, there's the risk of being unfamiliar with the routines of a unit, not having that team of colleagues that works together, and and without that, there's a breakdown in communication. And those are all things that really we know from past experience contribute to the quality of care or lack of quality.
It also hurts also because there's no support. There's your moral fiber. There's your support that you're lacking. You're mentoring. It's gone. It's not there.
We have a question from an individual. He wants, the person wants to know, where do you think nursing will be in 2025? We are in a crisis of nursing shortage. And in Massachusetts, we passed the mandatory overtime law, yet we are still getting mandated. So he wants to know where we will be in 2025 from your perspective.
To be honest, it's, and I'll look to Betty, because she's still boots on the ground.
Mhm.
But what I see kind of happening is, I think we're going to be bringing in support staff. We're going to be bringing back LPNs into acute care, which we haven't done in many years.
Yeah.
You're looking at a 15-year LPN. That's where I started my career, girl.
Right. But I mean, I think you're going to see the resurrection of the LPN. So it'll be team nursing. So we'll have fewer registered nurses on a given unit, but you'll have other supplemental staff to help that RN. It might be the only solution left.
Yeah, I mean, of course, I started out as an LPN and then ended up being put in an ICU working as an LPN because it was so bad. And the hospital actually made me go back, get my RN, but they also paid for it. So my nursing education was very cheap, just saying. But I love being an LPN. As an LPN, I mean, for me, it was 12 months training. It's not that anymore, my understanding. But you took care of a patient from day one, hands-on a patient from day one. So I think that patients get a lot better care from that type of nursing, as far as the good old, oh my God, what were they called? Come on, diploma nurses. I mean, the more education you give a nurse, the less time they touch a patient. Sorry, but that's how I feel. That's what we're here for. We're here to touch a patient, and you're right. We're going to have more support staff. Well, look how it is right now. When I started out, when I worked in the ED, one time I transferred from one ED to another, and they said, well, Betty, you're not letting us draw bloods, so whenever I got a patient, it was line lab, EKG, send them to X-ray. That's what I did. Well, I got yelled at by the CNAs because that was their job. And it's like, I never worked in a hospital that was your job. That was my job. So yeah, I'm seeing, I think you're right. We're going to see more and more of that.
I think we have to explain what an LPN is for the international audience.
That's great. Go ahead, Janet or Janine. Go ahead. Somebody do that, please.
So an LPN is a licensed practical nurse. So they're not trained to the same level as a registered nurse, but they can do quite a few patient care activities. They can, and you can correct me, Betty, but they can do assessments. They can give medications. They can
other IV, not IV medications.
No, not IV, or they can't give blood or anything like that, or chemo, but they can do your vital signs and give you other medications and
draw blood.
Yeah, draw blood. But at the end of the day, too, something to consider is if we have this influx of new nurses on the units, which it looks like is happening, the RN is responsible for the care delivered by that LPN and anybody.
Correct. You always worked under the direction of a RN.
Right.
Correct.
So if that LPN does something wrong, the RN is ultimately responsible. So even though you're bringing more manpower to the unit, you're actually putting more emotional stress on an
Correct.
RN, especially if it's a new nurse. And that's what seems to be the case. There are overwhelmingly new nurses in the hospitals.
Well, and then if you're going to be bringing all this travel people in too, it's people that don't know people. There's a lot of trust involved in that type of a relationship.
But at the end of the day, if we could bring technology in, and that could be another answer. I'm not quite sure what that might look like, but I think technology is really underutilized in healthcare. Speaking from nurses that can't stand playing with the computer and not playing with the patient.
No, I don't mean
that.
Talk to me.
Like at Emory, we have an EICU. So there's one of our hospitals, there's a huge room with these large monitors, and it's looking at ICUs in every hospital. And there's a physician or a nurse practitioner at those consoles 24/7. So if the nurse isn't around, they tell the nurse something's going on in that room, get to it. We had that at some hospitals that do that with their telemetry, and the thing that I didn't like about it, a lot of them, they didn't also have a screen on the floor so that I could also visualize my patient. Mm-hmm. I did not like that. But I think there's ways to bring in that kind of technology. That's what I'm saying. It might not be perfected yet, but that might be one of the ways. Yeah.
I would like to thank all of the panelists and the moderators, Chris and Janine, for a very enlightening and engaging panel discussion regarding frontline worker safety during the pandemic. At this time, the conference is drawing to a close, and in the next session, I will give an overview and closing remarks. Thank you all for such an engaging panel discussion.